Okay. And echo sessions are interactive learning communities, so feel free to have your webcam and mic on when available. We will go into breakout groups during our family study case study session, and then always use the chat if you need any assistance or have any question for our speaker or for me, and someone will definitely answer all of your questions. Renaming your profile, which we already discussed a little bit, but if you would like to, please feel free to rename. You can tap on the 3 dots on your picture, click rename, and then put your name, title, and where you work. And you can also insert all of that information into the chat. All right, and I'm going to pass it over to my colleague, our facilitator today, Rebecca Dosh-Brown. And she is my colleague at ICI, Institute on Community Integration at the University of Minnesota. Rebecca is the Interdisciplinary Education Director at ICI. In her role, she helps support interdisciplinary campus and community collaborations with the aim to improve systems and supports for children, young adults, and adults with disabilities. She is also a PhD candidate at the Humphrey School with a focus on youth disability policy. So welcome, Rebecca.
Great, thank you, Courtney. Thanks everybody for joining us today. It's nice to have you here. Again, my name's Rebecca Dosh-Brown, and I work with my colleague Courtney and Jen, Dr. Hall-Lande, who will be introduced shortly. But first, allow me to provide a brief introduction to Project Scope, based in Minnesota. Project Scope nationally stands for Supporting Children of the Opioid Epidemic, and our goal is to build a community so we can all share our knowledge and expertise on ways to better support children and families affected by the opioid epidemic in Minnesota. So we wish to increase support not only for children who are born with neonatal abstinence syndrome, or NAS, or neonatal opioid withdrawal syndrome, also called NOWS, but also children who are affected by growing up in homes where opioid use is occurring. We developed this series to build a community among Minnesota's early childhood providers and interventionists, but we also welcome people from all disciplines, backgrounds, geographies, including family members. So everyone is welcome today. And while you may know the ECHO model, as part of an ECHO, you have to explain it for those not familiar with the ECHO model yet. Okay, next slide, please. And Project ECHO stands for Extension for Community Health Outcomes, and it uses a hub and spoke model to connect rural and remote practitioners with specialists in urban areas to discuss cases that would otherwise only be, or cases or people or families that would otherwise have to be sent to the cities or larger distance health systems. So the ECHO model was developed way back in 2003 by Dr. Sanjeev Arora and his team at the University of New Mexico to address the need for training doctors and nurses who are working with remote and rural communities. As you know, remote towns and sparsely populated counties, it's difficult to access specialized care for chronic diseases, and if not impossible. So Dr. Arora back then decided to use teleconferencing to help fight widespread untreated hepatitis C by training rural and health professionals on how they could treat it right in their communities. Later, the same University of New Mexico expanded ECHO training to mental health, substance abuse, gestational diabetes, and soon all other states' large research universities adopted the ECHO model for their own rural practitioners. This all happened long before we had Zoom and comfort with Zoom. But from its origins to today, we could say the ECHO model is just designed so that everyone is a teacher and everyone is a learner. So we're here to learn from each other in a democratic way. And it's actually hoping to democratize, that's a hard word to say, democratize healthcare knowledge in general. So next slide, please. Briefly, the ECHO model must have 4 principles. So it uses the technology such as Zoom. It shares best practices in the field and topic. It provides a case study, but we prefer the language family story for our scope ECHO. And also it collects data on the training's impact for our audience so that we can ensure that we're being effective and that knowledge is being shared, together. And also it helps us improve the sessions as we go. So next slide, please. As we said today, today's session is number 2 of our 8 session series. Feel free to share the registration link for the training series with your colleagues and networks across the state. Next week's speaker is Susan Ballou to talk about early childhood adverse experiences, trauma, I can't see the print, but and also Indigenous approaches to support children. So please join us next week. All right. And today's session, our guest is Dr. Jennifer Hall-Lande, my colleague. Thanks for coming today. Dr. Jen Hall-Lande is a researcher and a psychologist at the Institute on Community Integration. It is a University Center for Excellence in Developmental Disabilities for the state. And also we are located within the Masonic Institute for the Developing Brain at the University of Minnesota. Her work focuses on early signs of developmental delays and early identification of developmental disabilities. Dr. Hall-Lande leads multiple disability-focused studies at ICI, including the Minnesota Autism and Developmental Disabilities Monitoring Network for the CDC. Okay, Jen, or Dr. Hall-Lande, are you ready to go?
I am. Can everyone hear me okay? All right. Thank you, Rebecca, for that nice introduction. And thank you to everyone for being here today. I know today was a busy day around the state with lots of trainings, and we appreciate you taking the time to be here with us. I will try and keep it interesting, if not exciting. And I have some videos to share today, so let's cross our fingers that those work. I'll try my best. And it looks like I have remote access, Courtney. Let me get started. Let me make sure I can. Oh, here we go. Oh, magic. Okay. All right. So today I'm going to talk about child development and opioid exposure. What I'm going to do today is sort of do a quick overview of some of the effects of opioids on the brain, and then talk about how it affects the developing brain and some of the developmental outcomes you may see for a child that was exposed to opioids prenatally. I have a couple videos today. I'm hoping they work and that the sound is good, but it should be good, and we'll have plenty of time for discussion at the end. So I will just get started. So I want to build a little bit on the presentation we heard last week from Liz Corey. The way we envisioned this series was to start very broad and sort of through a policy lens, sort of what is the state of the opioid epidemic. And then we're going to narrow in on more specific topics. But in the interest of connecting the dots across sessions, I just wanted to remind or do a quick review with everyone what some of the stats look like in the United States around opioid use. So the opioid crisis in the United States is an identified public health emergency. These data, and I want to tell you, you're going to hear this from speakers, we have yet to get the data over the pandemic. So this is 2019. So I guess one interesting point of it is we get to see a snapshot prior to the pandemic. And then we're hoping for our next session, we're able to get some more post-pandemic numbers, because what we're hearing nationally is that what we hear what we hear in the news, what we've been hearing in terms of trends is that opioid use and deaths are likely going up during the pandemic. And that sort of is not surprising considering some of the risk factors that go into substance abuse. But prior to the pandemic, we were saying about 11.1 million Americans misuse prescription medications. There are about 47,872 deaths from unintentional overdose, and 2.6 million Americans report an opioid use disorder, and all signs are showing that is only increasing. Use of heroin and pain medications by women have nearly doubled, and I actually have some data quadrupled since 2009. Delivery records indicate a quadrupling of opioid use disorder since 1999. So it used to be very uncommon for doctors that were delivering to see children with NOWs or NAS, and now it's much more common. And we're going to talk about that. Hopefully my slides will. So I wanted to do this is a very quick video, about a minute and a half, that tells a little bit how opioids work, what the mechanism is in the brain, because I want us to be able to draw a link from how it affects the adult brain. Because we know that if a pregnant mother is taking opioids, that her child is also exposed, that her unborn child. And so it's important for us to understand some of these mechanisms within the brain, how opioids operate. And I'm really hoping that this video plays. Courtney, can you give me a thumbs up, or Rebecca, if you can hear it? Oh, I think we're going to have to adjust the sound. No one's hearing that, are they? No. Okay, let's try it again. Courtney, if I turn it over to you, are you able to play? Okay, I'm going to let you play it. Courtney her speakers are connected, and I think we're going to have a problem. Take two on that.
One little trick, Courtney, is to click those two boxes at the bottom when you share your screen about audio.
Stand by. It'll play. If not.
Yep.
Okay, let's try it. Which two boxes, Rebecca?
There's two boxes at the bottom when you share your screen, when you first share it, that optimize audio.
Oh. Okay, can everyone hear it now?
What are opioids?
Yes.
Opioid is the catch-all term used to refer to a class of drugs called narcotics. Narcotics are used to reduce pain. They can also be used illicitly to create a sense of euphoria or high. Opioids are either synthetically manufactured or derived from the opium poppy plant. Prescription opioids are used to treat moderate to severe pain, such as post-surgery pain, cancer, dental pain, or sports injuries. Names of prescription opioids include oxycodone, brand name OxyContin, hydrocodone, brand name Vicodin, morphine, and methadone. Fentanyl falls into this category too, but it is also made and distributed illegally. Heroin is the main illicit opiate. Opioids, particularly fentanyl, are potent and dangerous. They carry a serious risk of addiction, misuse, overdose, and even death. Opioid overdose can be reversed if the opioid reversal drug naloxone is administered in time. Opioids work by affecting opioid receptors in the brain and nervous system. They work by sending messages to the brain that block the perception of pain and release large amounts of the chemical dopamine. Dopamine creates a sense of calm and euphoria. This sense of calm and pleasure can reinforce the desire to use opioids again, even when the person is not experiencing pain. When a person uses opioids recreationally, this is called misuse. Opioid misuse can lead to harmful side effects, such as addiction, slowed breathing, cessation of breathing, drowsiness, overdose, or even death. For more information, check out these sources, or visit us online at workithealth.com.
All right, thanks, Courtney. We can do the next slide. I think that audio was on super speed, by the way.
I was wondering.
I guess that saved us a little time. But next slide. All right. Wow, very fast talking. All right, so pregnancy and opioid use. Opioid use has increased more than 4 times in pregnant women since 2010. What survey data tells us, just random survey data in the US, looking at large groups of women of childbearing age, about 7% of women reported using prescription opioid pain relievers during pregnancies. Of those, 1 in 5 reported misuse of opioids. That's, for example, using them when they should not be. It's not their prescription, buying it illegally. The number of women with opioid-related diagnoses documented delivery increased by about 131% from 2010 to 2017. Be very interesting to see what these numbers look like post-pandemic, but the trends are increasing, and there really are no signs of, we have a lot of initiatives and we're doing a lot of work, but really the signs are telling us that we're likely going to see continued increase in that area. Next slide, please. So we're going to have a twofold discussion today, and to sort of wrap our brains around this, there's two things I'm going to talk about. We're going to talk about the immediate withdrawal effects of opioids on a newborn baby. So, and then the other piece we're going to talk about is the long-term impact on the brain, what the research has told us. So those are related constructs, but we want to talk about both, because when a newborn is born, and if they have been used to a relatively constant stream of opioids, they're going to go into withdrawal when they're born. And it's an uncomfortable process for them. And there's a lot of things the doctors do, nurses do to support them in the short term to sort of mediate some of those symptoms. Then we're also going to talk about the developmental impacts, what research tells us about the long-term developmental impacts. So first, I'm going to start with some of the withdrawal effects. Next slide, please, Courtney. So first, I'm going to talk about the neonatal opioid withdrawal syndrome, or what we're saying is NOWS. So that is the sudden discontinuation of fetal exposure to substances, in this case, opioids, that were used by the mother during pregnancy. Next slide, please. So we have a quick video. We're going to stop at about 2 minutes, Courtney. I'm hoping it's on a more normal speed, so it's not super speed, but this is going to talk about some of the symptoms, and then I'm going to walk us through it, that these hospital delivery wards are seeing with children that are born exposed to opioids. And I'm going to have you play that, Courtney, because your sound is working.
For infants that come into the world dependent on drugs, life has a rough start.
They sometimes have this loud, piercing cry in spite of everything that is being done for them. These babies are also very jittery, very irritable, difficult to console just by holding. Their respiratory system can be affected. They may breathe fast. Their gastrointestinal system may be affected. They don't do well with feedings. They may have vomiting and diarrhea related to their withdrawal.
Neonatal abstinence syndrome is where an infant is in utero, exposed to medications that could be prescribed or not prescribed. The infant, when delivered, has to withdraw from those, just like a mother has to withdraw. Depending on the medication, we have to provide medicines to help that patient or that infant withdraw slowly.
Unfortunately, weaning infants off those drugs has become a growing concern in Tennessee.
We are really in the epicenter of the problem within the United States. It's very centralized in Appalachia, though it is spreading across the United States.
In 2010, as the number of babies with NAS increased, the doctors and nurses at East Tennessee Children's Hospital discovered they were dealing with an epidemic that had no established medical protocols. So they created them, with an innovative care regimen that included a specialized NICU that minimized light and sound, a comprehensive system that scored symptoms, and one very hands-on calming technique.
It's the job of the cuddler to come in and hold them, rock them, and try to get them back to sleep. I like to talk to them and I tell stories. My singing is kind of bad and they fall asleep to that. Sometimes my yoga breathing puts them to sleep.
All right, thank you, Courtney. Next slide, please. So that was a video done by a hospital in Tennessee that has done, previous slide, that has done a lot of work, a lot of innovative work with babies with NOWS. And so that was a video that they done. We stopped it because then it goes into some other programming that they do, but they've done a lot of, they were noticing a high percentage of children born with NOWS, babies born with NOWS, and they've done a lot of sort of creative, innovative pro-family, pro-parent practices and have had some really good results. I would encourage you to take a look and learn more about that, or you can look back at the slide, but they've been a model for many other hospitals in that respect. But just to review some of the symptoms that they talked about that we see with babies born with NOWS, the doctor talked about a lot of central nervous system dysregulation. So a high pitched cry, irritability, hyper irritability is reported by nurses and parents and people that work with babies with NOWS. Hypertonia, really stiff muscles, hyperflexia, difficulty sleeping and regulating sleep and staying asleep. They really appear dysregulated. Again, hyper aroused is what a lot of parents and caregivers report. A lot of GI upset. So they often will have a very difficult time feeding, swallowing, sucking. Weight loss, that they're really not gaining or thriving, loose stools, diarrhea, more frequent spitting up. We also see a lot of nervous systems issues. So difficulty regulating temperature. We hear that a lot. So hypothermia, hyperthermia, nasal stuffiness, a lot of sneezing, excessive sneezing, sweating, yawning, fast heartbeat. So it's really, they're having a hard time regulating their system. When they come and have been exposed for an extended period of time, their brain is used to opioids at that point. Next slide, please. I won't go too into detail about some of the neurotransmitters and sort of what is upregulated and downregulated in their brains. But when the babies have been accustomed or they've been exposed to opioids prenatally, the brain expects it. So when they are born and no longer are receiving the opioids, it alters the neurotransmitters. And so if we think of sort of the biochemical underpinnings or the underpinnings of the neurotransmitters that underlie some of these behaviors that we see, if you remember from the video that went really, really fast, and it talked about, dopamine and we take, when we take an opioid and those dopamine receptors and we're increasing that, it feels good, right? And so when they no longer are exposed to that opioid, we see a decrease in dopamine. And so that is part of that hyper irritability we see in these babies, anxiety. They just are having a hard time regulating. It's not normal for them. We also see a decrease in serotonin, another sort of feel-good neurotransmitter. So they have a problem regulating and maintaining sleep. Their sleep is highly fragmented. They're hard to soothe and get to sleep. But then we start to see increases in other neurotransmitters when they're born and not exposed anymore. So we see, and that gets back to some of that dysregulation in temperature. We see this with the noradrenaline, hyperthermia, tremors, fast heartbeat. So we see that neurotransmitter go up. Acetylcholine, we see that go up. So we see diarrhea. You think about if we think about people talk about who are on opioids or painkillers, that one of their symptoms is constipation. So when you're in withdrawal, a symptom that you'll see is diarrhea. So you see how that works with the baby. Vomiting, yawning, sneezing, sweating. So we're seeing their system is dysregulated when they're coming out. And so they need a lot of special care. Next slide, please. So this is not every possible care for neonatal opioid withdrawal syndrome, but here's some of the common ones. And the video that we saw on Tennessee, they're doing a lot of this work and they're implementing a lot of this. So there certainly are pharmacological medication type interventions that we do with babies with NOWS. But there's also non-pharmacological, and those usually are the first line because they're not expensive. You want to try that first. They're accessible. They are strategies that the parent or caregiver can apply. But first of all, gentle handling. The babies are dysregulated, so they need a very calm and soothing environment. They often dim the lights. The video that we saw of one of the cuddlers, I watched quite a few videos on these, but often They have volunteer cuddlers come in and rock and hold the baby and comfort them. I don't know about you, but that sounds like a really good job to me. I watched a couple with grandparents doing it, but they're in these settings with dim light, quiet, calm. They're trying to help re-regulate this dysregulated system. Doing a lot of skin to skin contact, encourage the baby and the mother, kangaroo care. There is research that rooming in with the mother and is beneficial, highly beneficial for the baby and helping manage some of these withdrawal symptoms. And why I mention that may seem, wow, well, of course, to all of us, but there had been a practice prior of, especially when in states that treat opioid addiction in a more punitive way, that treat these mothers kind of more punitively or through a criminal lens of separating the baby from the mother and just having hospital staff care. More and more hospitals are implementing, in this hospital in Tennessee on the video, really getting the baby in with the mother. The baby needs the mother to help regulate and co-regulate, do a lot of that skin to skin contact that's very, very regulating for the child. Swaddling is very, very helpful. Again, one of my children had a very hard time regulating herself, and swaddling was very, very helpful. It's comforting to a lot of babies, but these behaviors in particular who need supports in regulating their system. They often frequent feedings. They're having a hard time with their sucking and working a lot of feeding in, so they need to be fed more frequently, and there's a lot more spitting up and a lot of digestion. The diarrhea piece and the spitting up are of concern. Obviously, a caring and non-judgmental approach with the family, a supportive environment for them is definitely an approach that shows much better outcomes. And yes, when many babies that have NOWs also will have to have a pharmacological intervention to help wean them off. Morphine is one of the most commonly used with these babies to reduce some of the symptoms of withdrawal. All right, next slide, please. So there was a very, very, Jody, and I see you have a question. I can't promise I'll see others. Are the mothers able to get treatment while staying at the NICU? That's a great question. And absolutely, I mean, I can't speak for every program, but for example, in the Tennessee program that was a model program, yes. I mean, they work, some of these moms have been in before and have come in and ordering in the system, many are not, and they work to get the family supports the mother treatment and start that process as well. So it's an opportunity for that. I really encourage you to take a look at some of these. Some sites in Canada are doing some really good best practices work around this and changing these practices. Babies need their moms. They need a caring caregiver, and how do we support the entire family unit to be more successful? So they're attending the medical piece, but certainly getting them connected in with treatment and social services. But then I'm going to now sort of pivot it. That was a very brief overview of NOWs, and I'm being very careful of time because I also want to pivot. As when Rebecca introduced me, I do a lot of work in early signs of developmental delays. I do a lot of work in early screening, early developmental monitoring, and early diagnosis. Most of my work is in the field of neurodevelopmental disabilities, but certainly what we see is children that are exposed prenatally are at a greater risk for developmental delays. So now I'm going to pivot. Do you remember my twofold slide where I said I'm going to talk a little bit about some of the immediate effects of NOWs, but then some of the lasting effects on brain development and what the research says about that. So we know that changes to the brain can occur in response to substances and exposure. That's sort of 101 brain development, right? That changes, substances can influence brain chemistry, brain structure, brain development. Next slide, please. We know that the baby's brains and through early childhood, our brains are responsive. We call it brain plasticity. They're malleable. That's why a baby can be born into any environment and learn the language. That brain comes in ready to learn. And so that brain is very open to new experiences. We really say little kids are learning machines, babies are learning machines. They're ready to absorb. Their brain is sensitive. And so it's sensitive to good experiences such as nutrition and prenatal care and warm, loving, responsive caregivers. But then next slide. The flip side of that is the fact that a child's brain is open to development, and it's what we call plastic. It also can be vulnerable to toxins and substances, exposure to viruses. So you kind of see that that's two sides of the same coin. I know many of us work in early intervention, and we work to provide supportive, enriching environments. On the flip side, it also is a time of great vulnerability to exposure, if that makes sense. Next slide. I'm going to talk a little more about that. So some of what the research tells us in terms of the effect of substance exposure prenatally, it can affect the visual center of the brain and retina. We know it has some effects. Opioids have an effect on that, or the research has said. I do want to say before I go into this, there is a spectrum. There is a wide spectrum. Even with neonatal abstinence syndrome or NOWS, there's a spectrum in terms of children's response and babies' response to that. So all of these may not be true for all children, but these are things within the research in large samples they say are increased risk factors. They see long-term deficits in working memory skills, poor inhibition. You think of kids with ADHD, they withhold an impulse? Can they inhibit a response? Abnormal sense of body in space. They see some of that. The children that have been exposed prenatally really can struggle with that. And then abnormal attention and learning. I'm going to go a little more detail on this and what the research says. Next slide, please. But we also know that prenatal exposure to opioids and really any substance is often confounded by many variables. That's the researcher in me talking, but we think about it. So a child prenatally exposed to any substance, they have a greater risk of being born premature. But then prematurity itself is also a risk factor. So it can be hard to disentangle some of these effects on development. We also see babies that are prenatally exposed to substances often have intrauterine growth issues. They often are low birth weight. We also know what we know from research on moms that have used opioids during pregnancy. It's often not just opioids, so that probably doesn't surprise people. It's usually polysubstance. So we often see opioids and exposure to cigarettes and alcohol and marijuana. It actually is quite rare to get just opioids. So you think about that in terms of contributions of those different substances. It also offers us a challenge as researchers. What really is the contributing factor? Parental education. In the samples that we have of looking at women that used opioids, it tends to skew to moms with, and this could be an artifact of our data, who we're sampling, but lower SES, lower parental education, confounded with a lot of parent mental health issues. It's pretty hard to disentangle addiction and substance abuse and mental health issues. And then, family genetics as well. So this is sort of multifaceted, and it does make it hard for those of us who are researchers to really know what the singular contribution is of opioids, but we do know research studies have associated these factors with opioid use, if that makes sense. There's never any easy answers, and sometimes research just gives us more questions, but I think it's important to think about. So childhood trauma and signs of its impact on young children. We also see higher rates of ACEs, adverse childhood experiences, with children that are exposed prenatally to opioids. We see physical, high rates of physical abuse, physical neglect, emotional abuse. We see these here, and we also know those are highly associated with regulation issues and increased anxiety and attention issues and aggression. So in many ways, it can be hard to disentangle that, but there's associations with that as well. Next slide. We also know children whose parents have used substances, whose mothers have used substances prenatally, may be at greater risk for attachment issues. We talked about the visual piece, and I'm going to break this down into developmental ages. But if a child is having a hard time regulating, and we know that attachment, all of you, I know I'm talking to a lot of experts here, is a bi-directional process between the caregiver and the baby. And we know a couple things, contributions from the mom, or the caregiver. If they're depressed or using substances, are struggling, their ability to be regulated as a parent, to co-regulate with their infant, that there's more challenges with that. If a baby is struggling to be regulated and also is having vision issues, we see this, this beautiful sort of attachment gaze here between the mom or caregiver in this case and the baby. Think of when I listed all the symptoms of a child with NOWS or baby with NOWS, all of the kind of challenges around that just in the area of attachment. So we do see increased attachment issues and challenges, yet we also know ACEs can contribute to that as well. So again, it's a complicated story. I know as we work with children and families, all of us are familiar with complexity, but again, the research can tell us a little, but it doesn't have all the answers. Next slide. I'm keeping an eye on time, Rebecca. I don't want to shorten your family story. So development, we do see children that are exposed to opioids, effects on fear and anxiety, issues with muscle tone and movement, and abnormal GI effects. We talked about that, the diarrhea, the spitting up. Next slide. Additional, we do need more studies on long-term effects of exposure to opioids. Like prematurity, the issues don't resolve with infancy. We don't just do some of those practices that we said with NOWS and then everything's okay. We know that there can be long-standing developmental issues. We also know that lifestyle, economic, genetic, social issues around developmental needs also need to be considered, and support may be needed through young adulthood, if not longer. Next slide. So the research tells us too that a child exposed to opioids prenatally, they have almost a 2 times, so an odds ratio is their ratio, the risk, and it's almost 1.87, it's almost 2. They're 2 times more likely to be low birth weight for age than a child not exposed to opioids. They're about 1.5 times more likely to be born premature. Next slide. As I look at this through the lens of different stages of development, I chunked it down into infancy and toddlerhood, but similar to what I showed you on that infant slide before, during that time between birth through 6 months, some of the things that we see with children exposed to opioids prenatally, we see a lot of issues with muscle tone. They often have delayed motor milestones. They also can have a lot of issues around stiffness in muscles. Torticollis, their neck, the way it may be stiff, and then they move it in sort of an atypical or abnormal way. Plagiocephaly, that, back flattening of the head from laying down on their back. We see that with kids, with a lot of infants, actually. Sensory issues, crying, not sleeping, that high pitched cry. I'm not sure if any of you have heard that. If you look on YouTube for children with NOWS, you'll hear that it's a really distinctive high pitched sort of atypical cry that you hear. They're very difficult to soothe, and we talked about those regulation issues. They do a lot of that backed arch flexing, and then a lot of just sensory seeking behaviors. Again, kind of we're looking at a baby that is really struggling to regulate themselves. Next slide. If we look at a little older infant at around 5 to 8 months, we're still seeing some of those self-regulation issues, sensory seeking behavior. We do know there's an association with the longer they're in the hospital, and for many of these children, they need to stay till they're regulated. The greater parent and child interaction dysfunction. So we've got this sort of medical model, they want them on the Finnegan, they want them to pass these sort of milestones before they leave. But we also know the longer a parent is there and a child, the more child interaction dysfunction we may have, and challenges with attachment, feeding, other things. And I think that's kind of interesting. It's sort of the medical model at odds with our developmental model there, right? Next slide. 6 to 12 months, we're continuing to see those motor development delays, struggles with feeding issues, sleep issues. We see that failure to use eye movements and track may also have some implications for attachment and social cognition. Next slide. And I'm moving along, Rebecca. I'm getting some helpful tips and I need to move it along. 12 to 24 months, the kind of toddler years. And I don't think these are surprising. Children prenatally exposed to substances, we're seeing a greater chance of speech language delays. I mean, that's our biggest sort of referral in general, in our general population. So it's not a surprise. We start to see the emergence of dysregulated sort of behaviors observed, like increased throwing, biting, head banging, sleep issues, and we are seeing some cognitive effects, some lower cognitive for children that are exposed. Okay, 24 to 36, the dysregulation. I mean, for those of you that really view things through the lens of development, we see how some of these issues like dysregulation and hypersensitivity, they take on a slightly different flavor that is consistent with sort of the developmental period, but it still is reflective of dysregulation, if that makes sense. So caregivers often describe this as sort of the terrible twos on steroids, that it really is just this intense activity and lack of inhibition and dysregulation. Difficulty playing with toys in a functional way, always moving, sensory seeking, poor attention, poor sleep, poor language development, and really kind of this association with hyperactivity. Next slide. And then 3 to 5 years, what research tells us that, again, I think some of the things we see sort of that are enduring are these motor delays, these attention issues, and some real challenges in terms of behavioral regulation. That said, it is hard to disentangle some of those other contributing factors that some of these children encounter as well. Next slide. I am really going to be very quick about the Boston birth cohort study. It's a large study. It's about 24,000 children that are tracked over a long period of time, and they are tracking moms from pregnancy and kids, I think, until the mid-20s, and sort of seeing some of the predictive outcomes of, you know, what their risk factors were, what contributing factors were to both challenges and success. They contribute a lot of data to this around early substance abuse exposure. What I think is interesting is sort of the age breakdown on this. So within the Boston birth cohort, when they were looking from 0 to 6, the kids' ADHD, I mean, frankly, not a lot of kids are getting an ADHD diagnosis from age 0 to 6 years, but that looked relatively normal. I think that's more of an artifact of when that's diagnosed, but they were seeing an almost twofold increase in conduct disorder, emotional disorder, behavior disorder in the population prenatally exposed, as well as just some abnormal motor development. Next slide. If you continue with this cohort after 6 years of age, you're seeing about a 2.5 times, that's another odds ratio of ADHD, significantly increase, almost 2 times conduct or emotional disorder. And again, that's going down a little bit. The kind of motor pieces still higher than kids not exposed, but not quite as significant as it was before. Next slide. And then, you know, we can just go to the next one. Just basically, these are just showing some of the risk factors around that research is identifying that children prenatally exposed certainly have a higher risk. We think about certainly in the ADHD, conduct, and some of the motor pieces. I am going to really go quickly over this part, but a lot of the work I do is public health outreach around identifying developmental delays early and getting kids earlier into services and supports, as well as their family, the service supports that they need. I encourage you to Google Learn the Signs Act Early. It's a great resource, free resource with lots of materials that help families and childcare providers identify developmental delays early and act early if they're concerned. We also have Help Me Grow. We can go to the next slide. In our state, that is also a wonderful resource if you have a concern about a child having a developmental delay. I will say these books, which are free and you can order them through CDC's Learn the Signs Act Early, these are storybooks that talk about what typical development is that a parent and a child can read together. I highly recommend you take a look at getting some of those free if you work with children and families. That's part of the Learn the Signs Act Early. And we also have a milestone tracker app that no advertisements, it's free. It's a wonderful app you can download to track a child's development. All of these are meant to help identify delays earlier and get kids the help and families the help they need as early as possible. Sorry, I went a few minutes over, Rebecca, but with that, I am going to turn it over to you. That was pretty fast. I'll take a look for questions in the chat.
All right. Thank you, Dr. Hall-Lande, for sharing that important information on the importance of early screening and some of the research on developmental outcomes for children born with NAS or NOWS. I'd now like to provide today's family story, and I think we'll skip the video. Go to the next slide, please. Yep. And the story that we'd like you to consider and discuss is about a mother and her son. Her name is Melinda Markham, and her son DeMichael is 8 months old and was born with NAS and NOWS or /NOWS. And just the background of the story, Melinda began using opioids when her daughter was first diagnosed with cancer. She was able to stop using briefly, but then started again after her daughter died at age 5. And then she became pregnant in that second episode. And by that time, she had moved from opioids to heroin during her pregnancy with DeMichael. Once she realized she was pregnant, she did seek out help for medically assisted treatment. Which is the gold standard for pregnant mothers. They are not supposed to quit because the risks are too high. The next slide. We like to give the strengths and also the challenges and barriers the family face. Melinda, a strength is that Melinda sought MAT when she was pregnant. So that's great. She found a center to stay at after she had her son, so she could continue her work and recovery. And she's been keeping her son's checkups at a NAS follow-up clinic regularly. And she herself has been in recovery for 8 months. Challenges and barriers the family face. Melinda has faced significant traumatic events. We mentioned her daughter's illness and death from cancer. She experienced homelessness right after giving birth to her son, but then she found the center for her recovery. There's some uncertainty for the family's future options after they leave the recovery center. And we know from research, relapsing is very common with opioid use. And in the video we did not watch, we did see that some of the clinicians working with Melinda and her son DeMichael were using what we would now call stigmatizing language, using words like addicts and such, which can have a negative effect on folks' recovery. These days we say a person has opioid use disorder, to kind of neutralize the language that we're using and reduce stigma. For our breakout group. Oh, and Jen, I forgot to prompt you to put those in chat.
I'm doing it right now.
Awesome. Okay.
Yes.
So before we go to breakout, we'll make sure Jen has everything in chat before we go. So you won't lose those details that I went over pretty quickly. But for the breakout, we have 2 questions. And, we want you to think about the strengths and the challenges. And for this family story, wherever you're from in Minnesota, think about the resources near you when you answer these questions. So how might Melinda and her son DeMichael be better supported right now to prepare the family for leaving the recovery center? And then second question, kind of related, what would you suggest the state, county, or city or town do to support the family's transition back into the community? So there might be like housing or healthcare or early development options that could support the family as a unit. So in your groups, we'd like one person to act as a note taker or reporter to jot down what you discuss as resources that might support the family. And this is where your expertise is welcome. And be ready when we come back to the large group to share some of the key takeaways in chat. That note taker and reporter should put those key points in chat, although anyone's welcome. Jen and Courtney, are we ready for breakout now?
Yep, we're ready.
Okay, and you'll be sent a breakout for 10 minutes, and then we'll come back and kind of recap the resources that we gather from you in chat. All right. Courtney, do you want to pause recording?
Sure. I actually can just stop it now because we don't want to share the specifics of
Oh, okay, great.
people sharing personal information.
Mhm.